Hi, I'm Y from Sandakan. Today I'm going to present about capsular bag preservation in the Shaky lenses. Prolene 6.0 to the rescue. This is a 75-year-old man with traumatic mydriasis and cataract presented to us with a pre-op vision of 360 and a very shaky lens. When I first saw this patient, I was thinking either I do a ICC for him and put in a sclera fix or ACLL, or I can do a phaco and put in a lens with a CTI and CTS. However, we don't have any CTS in our hospital. Then I came across the work published by Prof. Jing from China, which she described how to hold a capsular bag using a capsular hook modified from our Prolene 6.0 suture, which is readily available in our hospital. So I decided to give it a try and start the case as per usual. Try not to collapse the AC in a patient with weak zonule. The lack of counter force due to the weak zonule will make CCC a bit tricky. Thorough hydrodissection is essential to free the lens from the capsular bag. You can see the CCC is very mobile. Dialing of the cataract will be very tricky due to the weak zonule. I use horizontal chop to reduce the stress on the capsular bag. Doing quadrant removal, be aware of the flimsy capsular bag due to the weak zonule. Keep the AC form before you remove the phaco probe. I prefer to implant the capsular tension ring now while there is quadrant holding up the capsular bag. I use skin C and also microforceps for manual implantation of the capsular tension ring. After that, I will use phaco to remove the remaining quadrant. Then I will cut this double end Prolene 6.0 suture into half. Take one end of the Prolene suture needle and straighten it. Then you make a loop on the other end of this suture. Use a low temp cautery to heat up this loop. Without touching the loop, the temperature from the cautery will form a permanent band. Measure 1.5 mm from the band and cut it off. This will form a hook which can hold the CCC. Then prepare a 26 gauge long needle. Make a cornea incision opposite to the intended hook site. Puncture 2 mm posterior to the limbus at the intended hook site. This will ensure the needle enter to the sulcus. Insert the straightened Prolene needle from the cornea wound and dock it to the 26 gauge needle. Use the 26 gauge needle as a guide to externalize the Prolene needle. Then pass the Prolene needle intrasclerally for few millimeter. Then use one hand to pull the Prolene suture from the sclera and the other hand to guide the hook into the AC. Use microforceps to guide the Prolene hook into the AC and ensure it hooks at the border of the CCC. Once you are satisfied with the hook placement, you can cut the sclera end of the Prolene suture. Then we can implant the single piece LL into the bag as usual. Post-op, you can see the LL is very stable with the Prolene hook there. Case 2 is a 58-year-old man with a brunescent cataract, phacodonosis and also vitreous prolapse. I start the case as usual, making the 2 incisions over the cornea. You can see there's vitreous prolapsing out from the side port. Then I perform anterior-tracheotomy to clear the vitreous in the AC. After CCC, I noticed there is a zonular weakness, worse at 2 o'clock. I use iris hook to stabilize the capsular bag before phaco. Horizontal chop technique was used to minimize the stress over the capsular bag. After removing one quadrant, I use the gap to insert the capsular tension ring. Then we continue phaco to remove all the cataract. After that, we bend the Prolene 6/0 needle and straighten it, and cauterize the other end to form a hook. I aim at the point with the weakest zonular support, which is located at 2 o'clock. Similarly, I use the 26 gauge long needle. Prolene needle enter to the AC via the corner incision at 8 o'clock. Then we slowly externalize the Prolene needle. Then pass the Prolene needle intrasclerally. By pulling the sclera suture, we can slowly deliver the hook into the AC. Due to the posterior seepage of the vision blue, it is not easy to visualize the CCC. In this case, I purposely leave the cortex at 2 o'clock to serve as a guide, to ensure my Prolene hook capture the CCC. Then I implant the single piece IOL into the bag. Excess Prolene suture was cut and cauterized. Post 1 week, the patient vision was 67.5 compared to the vision of counting finger pre-op. With only one implantable capsular hook, the IOL appeared to be stable. We can see the implantable capsular hook at 2 o'clock with the retained cortex. The capsular bag is well supported by the hook at the sulcus, which is anchored to the sclera. The Prolene suture is well embedded in the subconjunctival space. In conclusion, for cataracts with weak zonu, an implantable capsular hook modified from a Prolene suture is an affordable option and is available in most hospitals. Unlike CTS or a Cionni ring, this technique does not require a sclera flap. Hence, phaco can be performed without a large wound as in ICCE, resulting in better visual outcome and faster recovery.